Hello, and welcome to another great AFM tutorial. In this tutorial series on clinical guidance during the COVID-19 pandemic, AFM aims to provide clinical resources on the management of COVID-19 disease with a focus on low-resource settings. However, please keep in mind that clinical guidance does not replace bedside decision-making, and all guidance here should be adapted to your local setting and to the patient in front of you. The first part of this tutorial series will focus on the process of screening and cohorting for COVID-19 disease, as they relate to emergency units. In this tutorial, we will go over what is screening and cohorting, what are the benefits, where and when to screen and cohort, how exactly does one screen, and here we will give an example of screening tools and even a video of the screening process. We will also go over outcomes of screening and implementing screening and cohorting in your EU and facility. You might be asking yourself, what is screening and cohorting? Screening is the process whereby undifferentiated patients are sorted into those who are likely to have COVID-19 and those who are less likely to have COVID-19. Once these patients are separated into these groups, cohorting maintains this separation throughout the patient's healthcare journey, from triage to treatment and right through to disposition and discharge. Cohorting is the grouping of patients with similar diagnoses and management together to facilitate and streamline their care. It is also sometimes called streaming or referred to as a clinical care pathway. Let's make these processes simpler to understand with an example. Here is a community with some people who have COVID-19 disease and some who do not. When they come to the health facility, they are screened at the entrance into the health facility before they even enter the facility. This separates them into patients at high risk for having COVID-19 disease and those at lower risk. Depending on this grouping, they are then moved into different distinct areas in the emergency unit, or EU as we call it. One for high risk of having COVID-19 disease, and one for low risk for having COVID-19 disease. Screening is the process whereby undifferentiated or mixed risk community members are separated out into two distinct groups, a high risk for COVID disease stream and a low risk for COVID disease stream. Put very simply, screening directs patients into two distinct areas and their respective cohorts within the facility and the emergency unit. Once in the appropriate area of the emergency unit, patients can be triaged according to how quickly they require care and receive care that is specific to their needs. In the COVID EU area, they receive care such as triage, testing for COVID-19, oxygen therapy, steroid treatment, resuscitation, or mechanical ventilation if it's available. In the non-COVID EU, or the normal everyday emergency unit, patients receive care that is specific to their condition, following local protocols already in existence, such as trauma care or diabetic care. The care received in the non-COVID EU is very much like the care that your EU provided prior to the pandemic. So we have an idea now of what screening and cohorting is, but why should we go through the trouble of implementing these processes in the first place? Firstly, separating suspected COVID patients from low risk for COVID patients helps stop the spread of the disease within your facility and community by minimizing patient-to-patient spread. During the COVID-19 pandemic, patients with non-COVID related conditions like heart attacks or car accidents still need to be cared for, and these patients should be protected as much as possible from contracting COVID-19 within your facility. Keeping these patients separated from COVID-likely patients will help keep community transmission down and protect these vulnerable patients from contracting COVID-19. Secondly, by having a cohort of suspected COVID patients in one place, staff can take extra precaution to protect themselves when entering such an area. The entrance to the COVID area can be signposted to alert staff to the risk of transmission, and can have hand washing posts and PPE donning and doffing stations at the entrance to facilitate safe PPE practices. Thirdly, Grouping patients with suspected COVID-19 in one place allows for streamlining of processes specific to patients with COVID-19 disease, such as testing for COVID-19 disease and oxygen therapy. The WHO recommends screening and cohorting for COVID-19 disease in all health facilities and in all transmission scenarios. The different transmission scenarios are those with no COVID cases yet, for those with a few sporadic cases, for places with clusters of cases, and finally, for places where community transmission is occurring freely. We have now looked briefly at what screening and cohorting is and why it is important. Now let's look at how exactly the screening process works. Screening is done by applying the WHO case definition. The WHO case definition has changed over time as we find out more and more about the disease and may be subject to future change. Please keep up to date with the latest case definition, which can be found on the link provided. Many regions may use a more inclusive case definition, and where a local case definition has been developed, this should be used for the purposes of screening as per local protocol. Here is the WHO definition of a suspect case as at the time of release of this tutorial. I know it looks like a lot, but don't worry. I don't expect you to read all of this. It's quite long, so let me highlight some important points in the case definition. As you can see here, the case definition relies on symptoms of acute respiratory illness, such as fever, cough, or shortness of breath. It gives a time frame of within 14 days since exposure, which takes into account the incubation period of COVID-19, and either a history of travel to a place where there's community transmission or living in a place of community transmission. Community transmission is another way of saying widespread person-to-person spread. It also says contact with someone who likely has COVID-19 or a patient who requires hospitalization with acute respiratory illness and where no other diagnosis is as likely as COVID-19 is. So when we say that screening depends on applying the case definition, a screening tool based on the WHO case definition, which we've just had a look at, may look something like this. I will give you a few moments to look at the slide. As you can see, a screening tool based only on the WHO case definition does not include the non-respiratory symptoms of COVID-19. You may have heard of some of these, such as loss of smell and taste, strokes, and so on. Some screening tools have been developed in different settings to account for this, and where a local case definition exists, it should be used for screening as local policy directs. Here is an example of a screening tool that includes the non-respiratory presentations of COVID-19. This is taken from the Western Cape Guidelines of South Africa. As you can see, this screening tool includes the symptoms of respiratory illness and possible contact with COVID-positive persons, as does the WHO case definition, but also goes further and includes other presentations of COVID-19 that are not respiratory in nature, such as delirium or stroke in a young person. Whatever the screening tool developed in your setting, screening is done by asking the person entering your hospital a series of questions directed at finding out their risk of having COVID-19. Let me play a short video to show you how this is done.
My name is Dr. Tselanyani. And what is your name?
My name is Ken.
Ken.
Yes.
And your surname,
My
sir?
surname is Diango.
Mr. Ken Diango. Nice to meet you, sir. Can I ask you a few questions? Do you have any fever?
Not really, I don't have any fever.
Okay. Are you coughing?
Yes, I've been coughing for the past 2 days.
Okay. Are you feeling short of breath?
Yes, from time to time. Yes, I'm struggling to breathe. Yeah.
Okay. Do you have a sore throat?
Not really, I would say so. Yeah.
Okay. Thank you very much, Mr. Diango. You can just proceed to that line, please.
Thank you.
Thank you.
Screening can also be done telephonically. In some settings, special numbers and call centers have been set up, whereby the public may call in and be asked a series of screening questions. Based on this, the need for testing and for hospital care may be established, and people may then be directed to specifically designated COVID-19 facilities. There is no one-size-fits-all for the response to the pandemic, and some settings may have designated hospitals while others see mixed COVID and non-COVID presentations. Now that we have talked through what screening is and how to perform it, it is very important to understand what screening is not. Screening is not testing. Screening is simply asking patients questions in order to understand how likely they are to have COVID-19. It is not a positive diagnosis for COVID-19, which is done by sending a sample, usually a nose or throat swab, to a laboratory or using a point-of-care test for COVID-19 disease. Although screening is very helpful to risk stratify who may or may not have COVID-19 and thereby facilitate streaming and cohorting of patients, it does not definitively tell us who in fact does have COVID-19. And while we may talk of patients at higher risk of having COVID-19 after screening positive, this should not be confused with people who are at higher risk of having severe COVID-19 disease, such as diabetics and older people, who if they do get COVID-19 are at higher risk of having a more severe disease progression. In the video we just watched, you saw a patient who, by answering yes to the screening questions, may likely have COVID-19. We call patients who we suspect of COVID-19 after screening screen positive, and patients who answer no to screening questions and who are less likely to have COVID-19 screen negative. Patients who also screen positive are sometimes also called PUI or person under investigation or suspect case. It is important to understand that the process of screening may miss patients with absent or atypical symptoms, and that as transmission becomes more widespread within a setting, patients with incidental COVID-19 disease who screen negative but still actually have COVID-19 may become more common. For example, a patient who presents with an orthopedic injury, such as a broken bone, may also have COVID-19 but not yet have any symptoms. There is no easy answer on how to address this, but contact precautions, good hand hygiene, and universal infection control practices combined with local policy may mitigate this danger. Great job so far.